Hi, my name's Andy Wolf. I'll be talking today about circumferential acetabular labral reconstruction and how it provides equivalent improvement to labral repair despite greater initial severity of damage and unfavorable patient characteristics at 2-year follow-up. I'd like to thank my co-authors. These are my disclosures. Several studies have shown improved biomechanical stability, decreased friction, and decreased load to articular cartilage with intact labrum or reconstruction when compared with resection. Promising clinical results in small series, particularly in patients with osteoarthritis, have been reported. Previous studies have demonstrated relatively worse outcomes in patients undergoing revision procedures with higher tonus grades and who are older. To date, I've performed over 600 arthroscopic labral reconstructions, and my technique has evolved and have found better outcomes in my hands with longer reconstructions. In January of 2014, I developed a robust infrastructure for data collection on current technique. This study reflects those patients available for 2-year follow-up at the time of the abstract deadline for ISHA. This is my technique. This is a 25-year-old hockey player with severely damaged labrum. I resected it and reconstructed from the transverse acetabular ligament anterior inferiorly to approximately the 8 o'clock position posterior inferiorly. You can see that the suction seal is restored nicely to the femoral head. At follow-up, this is a second look on another patient who is 18 months post-op, and you can see good incorporation and stability of the labral graft to the acetabular rim, including incorporation with the native labrum posterior inferiorly. There's good suction seal provided still with the femoral head by the labral graft. With this study, this was a retrospective review of prospectively collected data on patients who were operated on by me. We had 34 consecutive patients in the reconstruction group. All of these had moderate to severe labral damage. This included patients with segmental labral defects, including failed repairs, failed debridement, severe pincer deformities, ossified labra, intercalated os acetabuli, or acetabular rim fractures. In the comparison group of 49 consecutive repair patients undergoing procedure during the same time frame, these showed all of these showed minimal to moderate labral damage. These were the statistics we used. We defined failure as need for further surgery. Thus, in our reconstruction patients, we had 5 failures. 1 underwent a core muscle repair, and 4 underwent arthroplasty. All 4 of these had pre-op tonus grade of 2 or significant chondrosis at the time of surgery. 2 patients were lost to follow-up. In our repair group, we had 3 failures, including 1 core muscle repair and 2 conversions to circumferential labral reconstruction. The severity of the labral damage was evaluated in a separate side study, and we found that I could distinguish the labral severity with moderately good reliability, a kappa value of 0.66. Comparing the two cohorts, the reconstruction cohort was included 35% revisions, and the repair cohort only 4%. This was statistically significant. Significantly different also was the tonus grade, with the reconstruction cohort being 0.44 and the repair cohort being 0.11. These was also significant. The reconstruction cohort was on average 14 years older. This was significant as well. However, none of the outcome measures that we used were significant, had any significant difference, and you can see that they actually track very closely in terms of their delta. This is the IHOT-12, the HOS-ADL, the HOS Sport Specific, and the pain scores all improved very similarly. The modified Harris Hip score similarly, and satisfaction was very similar in both groups. In conclusion, patient demographics were significantly less favorable in the patients undergoing reconstruction. They were 14 years older, 35% of them revisions versus 4 in the repair group, and they had far more severe labral damage or defect. Thus, 2-year follow-up results of circumferential labral reconstruction approximate those of patients undergoing labral repair for more modest labral damage. Circumferential labral reconstruction may be a viable option for treatment for patients with moderate to severe labral damage or segmental defect. These are my references. Thank you.